All right. Good afternoon, everyone. Folks are logging in. Welcome to today's national audience webinar with the National Center for Medical Legal Partnership based at the George Washington University. As folks are logging in, we will not delay in terms of getting started. That way we can hear from our subject matter experts who are panelists, researchers, and MLP practitioners from the field and here at the George Washington University. So let me just open up formally and let you know what we're here to learn more about. So again, welcome. Today's webinar is really to help us discuss those findings and feature some examples from the MLP field from our Health Center MLP environmental scan. Let's go to the next slide. This particular training event is funded by HRSA through American Rescue Plan dollars. Thank you to the Health Resources and Services Administration. We here at the National Center for Medical Legal Partnership are a national training and technical assistance partner to HRSA. Let's continue. I am Bethany Hamilton, co-director of the National Center for Medical Legal Partnership. I want to thank you all for continuing to tune into our training and technical assistance events and encourage you all to not just review the recording from this event, but there's also a fact sheet that's forthcoming to present these findings. And there are additional resources on the National Center for Medical Legal Partnership's website. Let's continue. So today, as on previous webinars, just had some really quick housekeeping so you know how to engage. You are automatically joined on mute, but you are welcome to and encouraged to use the question and answers pane to submit questions. We have both Reha and Amalis from the National Center for Medical Legal Partnership team. Reha is running tech, so if you need any assistance, feel free to just send a chat to Reha, and you'll send that chat to the host of the webinar. You can also email us. Amalis will be later and throughout the duration of the presentation, reading out some of the questions that have come in through the Q&A. So again, if you need assistance, you're welcome to email us, but it's much easier if you utilize the chat. And again, we are recording, and both the recording of today's webinar as well as the slide deck will be posted on the medicallegalpartnership.org website under the resources section. Let's go to the next slide. So I mentioned that the National Center for Medical Legal Partnership is a partner to HRSA, providing training and technical assistance to community health centers, as well as health center controlled networks and primary care associations around the country. Our objectives through our work with HRSA is really to help health centers address population health by better addressing those health-related legal needs of patients. We help those health centers also increase health equity amongst their patient populations by screening for those unmet legal needs. And then finally, ultimately, as we are NCMLP, we're helping them actually build medical legal partnerships. So our aim is ultimately to increase the number of health centers that fully implement MLPs to address the social determinants of health. There's some things we definitely already know about health center MLPs. So let's go to the next slide. And we can scroll through. All right, start right here. What do we already know about the health center model? Number one, we know that this started through the war on poverty, and this is back in the 1960s. So it's a part of the civil rights movement. And the health center model is born of Section 330 of the Public Health Services Act of 1965. Presently, the health center program is administered by HRSA and is many of you know is commonly referred to, these health centers are commonly referred to as federally qualified health centers or FQHCs. Here's a did you know that I wanted to make sure ended up in this slide deck for educational purposes. The term FQHC or federally qualified health centers is actually a CMS payment designation for this for these health centers. Another did you know fact that I wanted to make sure everyone has and is clarified is that you have both grant funded as well as non-grant funded health centers. The Section 330 grant funded recipient health centers, they meet all of the health center program requirements and they receive a Section 330 federal award. Some of these are your community health centers. Some of these are focused on special populations such as migrants, your farm worker populations, those who are experiencing homelessness, as well as individuals who are in public housing. So these are different types of your federal award funded health centers. Some health centers, as I mentioned before, are not grant funded, but they act exactly like your federal grant funded programs. And so these are the health center program lookalikes. That is a specific HRSA designation. So you're not just an organization saying or calling yourself a health center. You are specifically designated by HRSA as a health center program lookalike. You're not a recipient of the federal award funding, not yet, but you're meeting all the requirements, and the benefits thereof are conferred upon you as a result of this designation. Some of those benefits include, for example, being able to participate in your Section 340B programs, or your receive that Medicaid, those Medicaid reimbursement benefits. The next thing that we want to make sure people know is how widespread the health center program is now. Back in 1965, they started with 2 health centers. These are your Geiger-Gibson program that's started in Mound Bayou, Mississippi, and then in Boston. Now, as of 2021, there are about 1,400 health centers operating at through over 14,000 delivery sites. And as of 2021, served over 30 million patients around the country. Let's go to the next slide and learn more about those services. Many of you are very familiar with this, but we just want to make sure you understand, for those of you who are not as familiar, what health centers actually do. What do they deliver? So number one, they are community-based and patient-driven. In fact, 51% of the health center board must be made up of active patients, so the consumers. They also are required to provide comprehensive, high quality primary and preventative care services, regardless of one's insurance coverage or ability to pay for those services. Those services can be medical, dental, behavioral, or other types of healthcare services that I'll emphasize in a moment. Those services must be delivered in a culturally competent and linguistically appropriate manner, and are often delivered by interprofessional or multidisciplinary teams. Here's what we want to emphasize. So you see in bold on the screen that health center services include enabling services. And as of 2014, those enabling services now include civil legal aid services, as an example of eligibility assistance or additional enabling or supportive services. To be able to find the source of this authority, take a look at HRSA's service descriptors for Form 5A on this slide deck. It is hyperlinked, and we'll be sure to send it out. Also, for health center services, they are collaborative. So these services are delivered in collaboration and coordination with other types of providers or programs, so that they're able to really address health equity, meet access needs, and improve quality of care throughout an entire community. Let's go to the next slide and talk a little bit about what the health center patient population looks like. So several of our NTAP partners or colleagues in the public health space who are conducting research on community health centers and health center programs include NAC and KFF. You'll see on the screen a screenshot from NAC's America's Health Centers 2022 snapshot fact sheet, just talking a little bit about what health center patients look like around the country. So in fact, number one, when you look at the American population, know that 1 in 11 Americans are actually health center patients, of whom 20% are uninsured. This is, by the way, a disproportionate representation of what how patients are served around the country. So also 59% of patients health center patients are publicly insured. 90% are low income. For those of you who are serving LSC or legal aid clients, some of these numbers may sound very similar to the individuals that you serve through LSC funded or legal services organizations. 65% of the health center patients are in minority groups, and 42% live in rural communities. Back in September of 2022, we asked our friends at KFF to help present to our NCMLP audiences a little bit more information about what the pandemic has done to patient needs. And so you see on the screen a snapshot of a slide that was presented by Brad Corallo of KFF, a little bit more information about the shifting needs of health center patients during the COVID-19 pandemic. And they did manage to capture data from the respondents on what legal services looked like. And you do see the increase in terms of legal services need represented in that slide deck. In our slide deck for today, that presentation is hyperlinked, and so you're welcome to and encouraged to actually view that recording. Let's go to the next slide. So this is why we're here today. It's really to find out what more do we know about the health center MLP model. But I just want to remind everyone what we did know about. We did know that approximately 163, sometimes we like to say give or take 10, health centers are operating or fully implementing the medical legal partnership approach to be able to embed lawyers as well as other legal services providers onto their healthcare team to help those patients really address those immediate social needs that are health harming and have legal underpinnings. This is how we address the social determinants of health and move from screening to actually addressing it with direct legal assistance, providing trainings to the health center teams to be able to strengthen how that health center workforce responds to the social determinants or social drivers of health. These health center MLPs are engaging in clinical level changes as well as policy change strategies to not just help individual patients, but also entire communities and patient populations. That's what we did know. It was very important for us to continue to dive deeper and learn more about what health center MLPs are getting done now and what might be some of the successes and challenges that we're facing. So let's continue moving on, and I'll happily introduce you to the folks who can tell you a little bit more about what they discovered, about what we don't or didn't know yet until we conducted a health center MLP environmental scan. I am very happy to reintroduce this audience to our colleagues here at the George Washington University. I'm actually going to start from the right and move to the left to introduce them, because you'll be hearing from Jacqueline Banos, or Jackie as we affectionately call her, here at George Washington University first and primarily. So first, Jackie Banos is Senior Research Associate with the Department of Health Policy and Management here at the Milken Institute School of Public Health at George Washington University. Jackie manages, designs, and executes research studies about transforming and improving public health and health services. She's an advocate for how public health investment and improvement can reduce health disparities and improve health equity, especially for underserved and historically marginalized communities. She's actually worked on several projects, including a study on strengthening Missouri's capacity to respond to public health crises, a cost evaluation of teaching health centers, and an environmental scan for us here at the National Center, the Health Center MLP environmental scan. Jackie's currently conducting research on how hospitals in California can address community benefits requirements. That's often tapped into, by the way, to support MLPs or their services. And she's also conducting a study about growing and sustaining the CHW, or community health worker field, in Missouri. She previously served as a presidential fellow at GW and worked in the Office of Diversity, Equity, and Community Engagement. She's an MPH and received that from George Washington University. And by the way, she and I are both presenting to you today from Georgia, or the Atlanta, Georgia area. Thank you, Jackie, for joining us. We are also happy to introduce to you, although she's not able to join today, but reintroduce to you a research scientist who has contributed to our work over the years in the MLP field, and that's Jen Trott. She's showing up there in the middle, a research scientist here at the George Washington University. I'm going to try to keep it brief so that you all can actually hear from everyone plus the MLP practitioner. So Jen Trott is lead research scientist in the Department of Health Policy and Management at GW. Many of you have seen Jen's past work for NCMLP, most recently on VA or veteran serving MLPs. So everything in her bio, including more current work, such as what Jackie has been working on with Missouri and on teaching health centers, I would strongly encourage everyone here to take a look at the National Center for Medical Legal Partnership website, the resources that Jen has really helped us to create on veteran serving MLPs. I have taken liberty to adjust that bio. And now I'm going to introduce you to Professor Dr. Marcia Regenstein, who is a professor of health policy and professor of health policy and management at the Milken Institute School of Public Health at the George Washington University. Marcia is here on the screen. You'll see her on the video, and has supported us once again in terms of finding out what's going on in the health center specific MLP field by supporting this health center MLP environmental scan. Marcia's work focuses on healthcare safety net and the populations it serves. Her most recent projects have focused on the community benefits in California, evaluating the cost of community-based primary care residency training, access to care for people with lifelong chronic conditions, state responses to COVID-19, the CHW and interpreter workforce. And hopefully what we'll be able to look into and dive deeper into in the future is really improving the quality and availability of language services, and then hopefully MLP services in FQHCs and hospitals. Many of you recognize, I'm sure, Marsha's name because for us here at the National Center, she has served in the past as Director of Research and Evaluation. Marsha has also served in key leadership roles in 4 multi-year quality improvement projects, including serving as the Director of Speaking Together, which is a multi-site project designed to improve the quality of language services in hospitals and expecting success, where she served as a senior advisor on research related to disparities in heart care among African-American and Latino patients. Marsha, thanks again for joining us. Jackie, thank you so much for leading today's presentation from the GW research team. I also want to make sure everyone understands the background and experiences of the MLP practitioners who have volunteered to join us here today. So let's move on to introducing you to the featured speakers from the MLP field. It is my pleasure to first introduce Rainey Thompson of Crescent Care. For over 22 years, Rainey Thompson has dedicated her life to protecting the rights of marginalized and vulnerable communities as an attorney. Rainey is a 1993 graduate of Jackson State University with BA in Poli-Sci and holds her JD from the University of Iowa's College of Law. Since 2015, Rainey has served as the Director of Legal Services at Crescent Care Health and FQHC in New Orleans. In this role, she supervises a team of attorneys who use the law to holistically address social determinants of health of persons living with HIV throughout the state of Louisiana. She worked as an Equal Justice Works Katrina Legal Fellow. I'm also an Equal Justice Works past fellow. So Rainey, it's so good to have a fellow EJW fellow with me on today's webinar. But as an Equal Justice Works Katrina Legal Fellow, Rainey was at Southeast Louisiana Legal Services until 2015. She also serves as a member of the American Bar Association Special Committee on Disaster Response and Preparedness and has trained attorneys, lawsuits, and advocates for social justice, both locally and around the country on disaster-related services, foreclosure defense, litigation, mortgage and foreclosure, rescue, fraud and scams, diversity and inclusion in the profession, and various other general financial awareness topics. Rainey, thank you so very much for saying yes right away and joining us today. It is also my pleasure and honor to introduce folks to Anna Kirkman. You may also recognize her name. Both of these MLP practitioners, by the way, have been in the field for a while. So it's probably been a while since you've heard from Anna, but she serves now as Associate Counsel and Medical Legal Partnership Director at Eskenazi Health, formerly Wishard Health Services, which is a safety net hospital in Indianapolis, Indiana. As Associate Counsel, she handles a variety of legal services, including involuntary civil commitment hearings. As Medical Legal Partnership Coordinator, Ms. Kirkman works to bring doctors and lawyers together to better serve the comprehensive needs of patients. Anna Kirkman was a recipient of the Indiana Lawyer 2013 Up and Coming Attorney Award. Congratulations, you need it again. And she's been presenting on mental health law in Indiana since 2011. She graduated cum laude from Indiana University's Maurer School of Law in Bloomington. And before joining Eskenazi Health, she also worked as a summer associate at Stiles and Harbison and at Figger Baker Daniels LLP. Anna, thank you so much for joining us today. To the audience, thank you so much for allowing me to fully introduce today's speakers so that you know their expertise, well-rounded experience in conducting research, supporting your work, and what they're currently facing in terms of overcoming those challenges in terms of implementing their MLP programs. All right, without any further ado, let's go on to presenting the Health Center MLP's findings. We'll hear from Jackie Banos of the GW research team. Jackie, all yours. Thanks, everyone.
Thank you so much, Bethany, for that introduction. I'm very happy to be with you today. As Bethany mentioned, my name is Jackie Banos, and I'm a researcher in the Department of Health Policy and Management at GW in the School of Public Health, working with the National Center for Medical Legal Partnership. I'm pleased to be here and have the opportunity to share the results and findings from the environmental scan of MLPs in health centers. Next slide, please. And most of you will probably already know this information. It's some of what Bethany just shared with us, but I wanted to provide some context for the environmental scan and context for our approach, including how we define a medical legal partnership and the role of MLPs in health centers. So we defined a medical legal partnership as an intervention that embeds civil legal aid professionals within a healthcare organization to address health harming social issues that have remedies in civil law. And this is commonly implemented through an agreement known or arrangement known as a memorandum of understanding or other agreement with a civil legal aid organization or other pro bono services to facilitate the provision of these legal services to patients. So as we talked about in 2014, when HRSA recognized civil legal aid as an enabling service, health centers became a fast-growing sector for MLP activity because they have substantial knowledge about the communities they serve, and they provide care to some of the most vulnerable and underserved populations. They make legal services accessible to people that might not otherwise seek out legal services and aid or might not recognize the practical help that legal services can provide. The MLP model can reduce health disparities and improve health equity for these communities and improve health outcomes, increase patient engagement, and lower healthcare costs. So this environmental scan features up-to-date information about MLPs in federally qualified health centers or FQHCs and lookalike programs. And just as a note, we refer to both of these as health centers throughout. So next slide, please. And for this scan, we wanted to get as clear of a picture as we could to the number of MLPs in health centers and their characteristics. We wanted to design a scan that would reflect these programs and generate meaningful information without burdening our respondents. And so for our approach, we ultimately designed 2 questionnaires. And the first was a brief screening questionnaire that was sent to health center administrators that would help us determine if a health center had an MLP and identify the health center's practices related to patient legal needs. And in this screening questionnaire, we asked if the health center screened patients for potential health harming legal needs, and we asked if they referred their patients to civil legal services. We also asked if the health center had an MLP according to our definition, and if they did not have an MLP, we asked if they were planning to establish an MLP within the next 5 years. This questionnaire was distributed throughout February 2023 and yielded a 20% response rate, so in total about 300 respondents. If a health center was determined to have an MLP, then they received a brief follow-up questionnaire that collected more information about the MLP. And this questionnaire was designed to help us understand the health center MLP characteristics. So for example, we asked a variety of questions like when the MLP was established, if they specialize working with certain conditions or populations, why patients were referred to the MLP, what legal issues they addressed, and we asked about some challenges that they might be facing, just to name some. And we were able to identify 99 health centers out of the 300 respondents in the screening questionnaire that we sent to health center administrators. 99 had an MLP, and we know that that doesn't capture all the MLPs in the country, so we provide an estimate given our data. And we also identified an additional 66 health centers that reported being in the planning stages of establishing an MLP. And this questionnaire yielded a 58% response rate. And so we were able to gather some really interesting information about these MLPs that we'll continue to explore in the next few slides. So next slide, please. So given the number of MLPs that we identified through the environmental scan, again, 99, we estimate that there are approximately 150 to 200 MLPs in health centers, with an additional 100 to 150 in the planning stages. So MLPs in our scan are in 27 states across the country, including DC and US territories. And a majority of these were established after 2014, after civil legal aid was deemed an enabling service by HRSA. However, there are a handful in our sample that existed prior to 2014, similarly to Crescent Care and Eskenazi Health that have been around, and we'll be hearing from them later today. And of the health centers that we identified, or health centers with MLPs that we identified, some of these existing MLPs also reported plans to expand their program by bringing on more dedicated MLP staff, increasing the time of the legal professional, and expanding to other health center sites. And in addition to the number of health centers that were in the planning stages, we had some health center respondents indicate that they would be interested in establishing an MLP were it not for certain limitations or barriers. So for example, one health center noted that they would be interested in establishing an MLP. They know it would be helpful and beneficial for their patients, but that the closest legal partner was over 100 miles from the health center. So for that health center, they felt that an MLP was not currently feasible. However, as we know, since the pandemic really forced healthcare and other sectors to rely more heavily on virtual operations or telehealth visits in the case of healthcare, we suspect that this virtual communication and more hybrid environments may create an opportunity for health centers in rural areas, for example, or areas with limited legal organizations or resources to explore or establish an MLP. So next slide, please. So as a part of this scan, we wanted to understand the health center practices related to their patients' legal needs. And in the screening questionnaire that was distributed to health center administrators, we asked health centers if they screen patients for health-related legal needs, for issues, for example, related to housing or utilities, income, employment, education, personal and family stability, to name a few. And we also asked if they refer patients to civil legal aid and services. And as you can see, 72% of our respondents indicated that they screen their patients for potential health-harming legal needs. And 63% of respondents indicated that they refer their patients with health-harming legal needs to civil legal services. Next slide, please. So this graph goes into a little bit more detail about that. This graph shows the relationship between screening and referral practices in health centers and MLP activity. So the screening practices are reflected in the blue bars, and referrals are shown in yellow, sorted by respondents' MLP activity. So health centers with an MLP, health centers planning an MLP, and health centers with no MLP activity. These represent responses from the 300 health center administrators from the screening questionnaire. And these health centers with an MLP were more likely to screen for health-related legal needs and provide referral services to civil legal aid compared to health centers without an MLP. So further, health centers that were planning to establish an MLP were also more likely to screen and refer than health centers without any MLP activity. So if we take a closer look at health, for example, at health centers with an MLP and their screening practices, 87% of these health centers are screening, whereas health centers with no MLP activity, only 64% are screening. And this comes to be a 23% difference. This difference is a little smaller when you compare the 87% of health centers with an MLP that screen to the 73% of health centers in planning that screen, a 14% difference. And there's only a 9% difference between health centers planning an MLP and those with no MLP activity that are screening. And we see larger differences still among health centers with referral practices, depending on their MLP activity. So 93% of health centers with an MLP reported referring their patients to legal services, whereas among health centers with no MLP activity, only 44% refer. And this came to be a 49% difference. Again, we see a similar jump in the difference between health centers with an MLP that refer and health centers in planning that refer. That comes out to be a 34% difference. So similarly, there's a 15% difference in health centers planning an MLP that refer their patients to civil legal services and health centers with no MLP activity that are referring. So just to reiterate, health centers with MLP activity were more likely to screen and refer compared to those with no MLP activity. Next slide, please. And we also, as a part of the scan, wanted to understand the kinds of patients that MLPs were serving and the kinds of legal issues they were addressing. So to understand the kinds of legal issues MLPs were addressing, we asked our respondents to indicate the top 3 reasons why a patient was referred to the MLP. In other words, what were the top 3 legal issues that the MLP most commonly addressed? And just as a note, this is coming from the second questionnaire about the MLP characteristics. And we were able to identify 4 legal issues that MLPs commonly addressed across respondents, which are shown in this graph. And as you can see, legal issues related to housing and utilities were addressed by a majority of MLP respondents, about 82. That was a reason why patients were being referred to the MLP, followed by about half that reported working on issues related to public benefits and family law. And a little more than a third of health center MLPs reported working on issues related to immigration. Some MLPs also reported working on patients with legal issues related to disability, issues related to discrimination in the workplace with healthcare access, and issues related to name and gender changes, healthcare directives, wills, power of attorney, for example. And so we also asked MLPs if they worked with certain conditions or populations, and 51% reported that they did work with certain conditions or populations. And for example, MLPs assist people with HIV or other chronic conditions, those with low incomes, individuals experiencing homelessness. MLPs also reported working with families and children, Latino communities, for example, and immigrants. Next slide, please. And all this great work does not come without its challenges, and we wanted to understand the challenges facing MLPs. So respondents in our scan with an MLP cited a variety of significant challenges in sustaining and expanding their programs. Similarly to the last question, we asked respondents to indicate their top 3 challenges with expanding or sustaining their MLP. Among most MLPs, 80% cited the need for stable and permanent funding. So funding was a major challenge. And 63% of health center MLPs reported receiving external funding from things like donations, foundations, grants, or payments from insurance payers. And most of these MLPs, the MLPs that were receiving external grants or funding, almost all or most of them cited the need for funding as a challenge. We also had about a dozen health centers indicate that their MLP was no longer in operation, and almost all of them noted that it was because of a lack of funding. Other challenges, as you can see, were lack of awareness of MLP services and value, staffing shortages, and competing priorities in the health center. But as you'll note, demand from patients and low interest from clinic staff and providers were not among the major challenges for MLPs. So overall, challenges that were commonly identified were related to resources like staffing and financial resources to sustain the MLP, and shows an opportunity also for ensuring that everyone across an organization or in the community are aware of the services and value of an MLP. Next slide, please. So along the same lines of challenges, we asked a series of questions to understand how operations might have shifted or changed as a result of the pandemic for MLPs. And we found that the pandemic really shifted how MLPs were able to operate and address patient needs at health centers, especially in terms of in-person interactions. So for example, for partnerships and programs like MLPs, the in-person interaction or that warm handoff is a really important part of the referral process. It helps establish trust and rapport, and it makes it an especially accessible service if it's right there in the clinic, if the doctor or nurse or your practitioner can just walk you across the hall or a few, maybe 100 feet to the MLP staff. But we found that the pandemic really interrupted this process. A shift to telehealth and overall lower patient volumes during the pandemic contributed to a decrease in MLP interactions with patients. So 65% of MLPs reported a decrease in in-person interactions with health center patients. Patient referrals to the MLP and the number of clients served also decreased. Some MLPs reported that they had to limit appointments or that the focus on COVID left less resources or staff to dedicate to the MLP. Additionally, some MLPs noted that the shift to virtual operations and telehealth visits made it difficult to establish rapport between MLP staff and patients. Despite these challenges, though, health center MLPs were able to maintain the dedicated time from the MLP legal professional. They were able to maintain their funding and maintain the variety of legal issues they were addressing. In some cases, MLPs noted that they took on more cases related to the evictions, right, during the pandemic, but they were generally able to address the same kinds of legal issues. So as health centers and MLPs emerge from the pandemic, they are reestablishing on-site and in-person interactions, like on-site presence, and working to reestablish or rebuild the trust and rapport between patients and staff. So currently 63% of MLPs are maintaining an on-site presence at health centers. Next slide, please. And this graph goes into a little bit more detail on what we just talked about. On the left, we have MLP in-person interaction, patient referrals to the MLP, and the number of clients served by the MLP. The light blue bars indicate that this process or operation increased. The yellow bars indicate that it stayed the same, and the dark gray bar indicates that this process or operation decreased. So kind of strikingly, you'll note that MLP in-person interaction decreased for a lot of our respondents, 65%. Patient referrals decreased for a little over half of our respondents, 55%. And for 47%, so about half, the number of clients served also decreased. And, you know, as you can see, some health centers reported that some operations were staying the same in terms of MLP in-person interaction, patient referrals. We're seeing the same for 28 and 21% respectively. And for about a third of MLPs, the number of clients served stayed the same. Interestingly, though, you'll note, while not for a majority, 19% of MLPs reported that there was an increase in the number of clients served. And for 24% of our MLP respondents, there was an increase in patient referrals, which could have been due to an increase in legal needs among health center patients that was driven by the pandemic. So we saw changes, with public benefits or with housing, for example. So next slide, please. So this brings me to the end, but ultimately our scan reemphasized some of what we already know about the impact and importance of health center MLPs. Health centers have the capacity and opportunity to reach people and communities that are likely to have health-related legal needs. MLPs and health centers can make these services accessible to people that would otherwise maybe not seek out legal aid or have access to legal resources. And so it's difficult to estimate the number of MLPs, but from this scan, we glean that there is interest in growth. There are currently 100 to 150 health centers in the planning stages of establishing an MLP, with current MLPs also looking to expand their programs. But funding continues to be a major challenge for sustaining and expanding MLPs. Luckily, there's a very helpful hub for all things MLP and MLP technical assistance, especially. The National Center for Medical Legal Partnership engages in education, research, and technical assistance, and advocates for the integration of legal services in healthcare, and they help healthcare organizations better leverage legal services to address health-related social needs. So they have a variety of resources that I encourage you to take advantage of, and they're available on their website. So thank you so much for your time today. I look forward to answering any questions you may have. And I know next we'll be hearing directly from the field from 2 health centers with their own MLPs. So I'll turn it back to you, Bethany, and thank you again.
Thanks so much, Jackie. Excellent presentation. So I'm going to turn to Amalis. A question did come in via the chat to make sure we pose it. If you want to hold it until the end so that others can also chime in, feel free to just let Amalis know. Amalis?
Sure thing. So we got a question about the family law issues that you all identified in the survey. So asking more specifically if you have a breakdown of the types of family law issues that these MLPs were dealing with. And the second question would be if any MLPs are dealing with criminal related matters other than expungement.
Marcia, feel free to chime in if I miss anything. We don't have a breakdown of the family law issues. We tried to keep the questionnaire as brief as we could, while also, getting as much information as possible. So finding that balance. So we unfortunately don't have a breakdown of that, but definitely something to explore further. Marsha, was there anything else?
No, that was it. And just about the criminal, did anyone mention anything about criminal?
I do remember seeing criminal related things like expungements, and there was one other, but it wasn't very common. I can go back to the data and pull that. But I think for the most part, it was mostly about expungements.
I'll just add for Jamal Applewhite, who posed the question, we, by the way, copied and pasted for the entire audience a two-part question that came in. And if folks want to take a look at our NCMLP resources, there is a recording from our webinar presentation by a newer medical legal partnership model out of Rhode Island, where they are doing more than your criminal related matters that are centered on reentry, like expungement. So take a look at the NCMLP website. In the meantime, I will see if we can find a link to it so that folks can check out that webinar presentation by folks in Rhode Island who are partnering with a public defender's office to carry out and implement a medical legal partnership. Amalis, do we have any more questions for Jackie and Marsha?
No more questions for the audience for now.
Thank you. Thank you, Jackie. Thank you, Marsha. So now we will move into the part of the presentation where you all get to hear directly from MLP practitioners, first starting with, again, Rainey Thompson, Director of Legal Services from Crescent Care in New Orleans, Louisiana. Rainey, it's all yours. And thank you again for joining us.
Hi, everybody. Thanks again for the opportunity to share what we're doing down here in New Orleans at Crescent Care. I am Rainey Thompson. I am an attorney. I am the director of the Legal Services Program here at Crescent Care. Next slide. So we like to tell folks when we are talking about the work we do here that we are actually working for health and justice. We are a unique program in that our department is actually integrated within the federally qualified health center, which is Crescent Care here in New Orleans. But the other unique thing about us is that we are a statewide program that is also partnered with and operating an MLP model with probably about 15 to 20 other community-based organizations around the state of Louisiana. But we started out as a separate nonprofit law firm in 1989 with our focus on working with persons living with HIV and AIDS. And Crescent Care, which was formerly No AIDS Task Force, it formed in 1983. So the two organizations until 2012 existed as two separate organizations doing the same work together, but merged in 2012. And brought the legal services piece into the clinic, integrated it into the clinic model. And so really tackling those health harming legal needs holistically at the intersection of where they meet, and also collaborating with those other organizations and expanding our reach into other vulnerable populations, as you'll see through my presentation. We're a small program in terms of staff size. Crescent Care as a whole has probably close to 300 employees. We are a 7 attorney strong program, and that 7th attorney includes me. When I can do the legal work, I do it. But an amazing staff of folks and 2 legal secretaries who are definitely committed to the work that we do and do some tremendous work in terms of advocacy and outreach and protecting the rights of our clients. And again, we do focus on a particular population, primarily those who are living with HIV throughout Louisiana. Primary office is located in New Orleans, and we've got a smaller office in Baton Rouge. And we've got attorneys who are based in New Orleans who travel statewide as well. Next slide. So this is our mission and model. We are strengthening the entire community through whole person healthcare and education. I've said it before that it's a holistic and comprehensive integrated approach to health and wellness. And this department is, again, unique in that we are integrated into the clinic's service model. And the organization provides a host of wraparound supportive services to every patient of the clinic. And as you can see in the slide, that starts with primary medical care. We've also got behavioral health. We do some prevention services, community health and outreach. A really strong part of our ability to do what we do is that we've got a strong team of dedicated case management staff and housing staff who work with our patients to ensure that they stay connected to us and are referred to us when there is a legal issue that's spotted. Next slide. So these are the issues that we tackled through direct legal services, advocacy, impact litigation, education, and outreach. As you can imagine with this patient population, historically, the need to address public benefits, discrimination, and permanency planning, when we started at the height of the HIV epidemic in Louisiana, those were issues that we knew we were going to have to address, and they continue to be the primary referrals that we get for the services that we are able to provide. But we've expanded our reach as, our patients are living longer with medical advancements, and so we're continuing to provide that support. We still see a lot of discrimination. We're in the Deep South. There's a tremendous amount of stigma and discrimination associated with living with an HIV diagnosis here. So it shows up in a variety of spaces, which we are in position to challenge and address some policy changes, both with employers, but also at governing body levels, both local and state. And then we've partnered with some community-based organizations to address some of the legal needs for persons who are members of the LGBTQ community. Specifically, we've been able to support the work of folks who identify as transgender with obtaining name and gender marker changes. And this particular patient population does not have to be HIV positive to access our services. And then in 2019, we added into our workflow the substantive work around immigration, providing legal services to children who are undocumented or unaccompanied, who are in Louisiana in need of legal services. Next slide. One of the things that we are really excited about is we received funding from the city of Baton Rouge as a part of their work to end the HIV epidemic. And this funding allowed us to really kind of deepen our reach into the community, removing some of the barriers that are in place for accessing our services. The way that the Ryan White system of care is designed, if you're not familiar with it, is that the goal of that system is to ensure that persons who are living with HIV are in this continuum of care, like they are in care, receiving the supportive services that they need, and that they are retained in care so that they can continue to, adhere to their medication regimens and keep their medical appointments and those sorts of things. And so one of the requirements to access the legal services that we provide is that referral has to come through a case manager. It's a case management based referral system. But with grants like this and some other funding that we have, it removes that barrier. We become a point of entry for those patients. And so it eases our ability to reach a little bit further into the community, target particular areas of the community, do a little bit more intentional outreach and education within the community, and build alliances and collaborative partnerships with other agencies who might not be a part of the regular provider list under the Ryan White Part A dollars that we are funded primarily with in terms of being able to do this work. The program has been extremely successful. We've really kind of launched it in December of last year and identified 30 new cases. And that was as of January this year, at the end of January this year, but it continuing to increase and have done a lot of community engagement in public spaces. as challenging as that is to do, but we've been successful at doing that. Hired a really great attorney who is passionate about the work as well. And this has also allowed us to identify one of our existing partners in Baton Rouge who is interested in designing an MLP as we're operating here at Crescent Care. So we're in conversations with them about integrating our work actually in their clinic as well. Next slide. And so these are a couple of the projects that I've already mentioned, but the work that we're doing with the folks with the Children's Immigration MLP is in partnership with the New Orleans Children's Health Project. And that's a clinic here that is, it's based in the same location as, it's based in Crescent Care's building. So we're in the same building, but it's a pediatrics clinic formed by Tulane University Medical Center, staffed by Tulane folks, Tulane's providers. But we identified the need with that clinic, and we are integrated in the work that they do as well. We've received since its inception 125 referrals. 80 of those referrals have received legal services. 36 SIDGE applications were approved, and 53 Medicaid and clients were enrolled for Medicaid. And the result is that now we have those children who now have health insurance through Medicaid, and it's reducing the number of patients who are on sliding fee scales to get access to medical services, and reducing the number of folks who also need financial assistance through various programs. And in our name change clinic, we've served approximately 56 clients over the course of the last 2 years, 18 months or 2 years since we've been doing that work. It's really exciting to be a part of that as well. Next slide. And so these are a couple of statistics in terms of what the work looks like, the impact that we have. These numbers, we did see some decline because of the pandemic, but over the course of the past year, we opened 463 cases, we closed 450. As of January, at the end of January this year, we had 381 cases open. More than unduplicated clients were served, more than 8,000 hours of service were provided to those clients, and more than 200 hours of outreach, education, and advocacy work was done. With our discrimination work, we were able to settle cases that total approximately $59,418, and those dollars went directly into the pockets of our clients, and we were able to collect attorney's fees as well. Social Security, again, has always been a high demand substantive area of law for us. And so we work really hard to get secure income for our clients. And again, this number was a little lower than in years past, but more than $200,000 of back pay and more than $17,000 of ongoing benefits for folks who qualified for those services. Next slide. I think that's the end. That's the end of my presentation. I'm open for any questions that anybody might have about the work that we provide at this point. Thank you again for this opportunity.
Thank you, Rainey, for offering this information to the national audience of medical legal partnership practitioners and health centers around the country. We are joined by a lot of different types of MLP stakeholders and practitioners. And there's a question that came in via the Q&A that we want to actually try with you first, Rainey, and then we'll bring it back. So Amali is going to pose that question.
Sure thing. So we got the question from the audience asking if any respondents from the MLP scan mentioned any success or best practices about their MLPs transitioning to virtual interventions during the pandemic. So we wanted to get your thoughts on that, Rainey, as well, and also open the floor to Jackie and Marcia.
So it was interesting that we were developing our statewide part of the program when the pandemic was, there when it started. And so we were, identifying technology and other resources that we would need to really make it successful, because we knew we were going to be in some legal deserts in the communities, some extremely rural territories. And so how would we do that? And so I think over the course of the last 3 years, we understand that it's tough to do that work. But the best thing that we could do was, Crescent Care was able to secure funding that would allow us and the rest of the staff to stay in communication with patients. And so that meant securing funding and buying dedicated cell phones that those patients could use strictly for the purpose of communicating via text message with staff, with their case managers, and those sorts of things. I think expanded the use of our electronic health records and case management system. And we're also looking at that. One of the things I think for legal services department is, exploring how do we design a system with this particular patient population where we can communicate through technology, like utilizing our case management system to do text messaging. I think things like that is what we've learned, that there are opportunities for us to improve and stay connected with community when we are remote and not on the ground as frequently as we'd like to be.
Thanks, Rainey. We had another question come in, and I'm just going to ask Pat, I want to confirm that we did receive your question. And if you don't mind, I want to hold it. It's a great question about sharing of patient-client information, including outcomes of the physician and healthcare providers. Rainey started to get to some of that, but I know and understand the question that you're posing, and I think it would be great for us to allow Rainey and Anna to pose that at the end during the larger Q&A. So let me see if Jackie and Marcia had anything to add about that previous question that Rainey addressed.
I'll quickly mention, we didn't ask about best practices. So, and I quickly looked through, so there wasn't really anybody sharing about best practices. Our question really focused on the challenges, but definitely another place to continue exploring or learn more about.
Agreed. Thanks, Jackie. Thanks, Rainey. All right, so we're going to move to the next MLP practitioner presenter. Just want to remind folks that, again, we are recording today's webinar. It's a 90-minute webinar. I did not mention that at the top, but it is a 90-minute webinar. We're really doing well on time. And so next up is MLP practitioner from Eskenazi Health, Anna Kirkman, who serves as Associate General Counsel of Eskenazi Health Center in Indianapolis. Anna, thanks so much for joining the NCMLP audiences again, and I'll turn it over to you.
Thank you. Thank you for having me. And Rainey, it was such a joy to hear about your program. And I was delighted to see some of the similarities that we have in our range of service. So if I could have the next slide, please. So who are we? I want to just step back and introduce Eskenazi Health. Eskenazi Health is part of the Health and Hospital Corporation of Marion County. So Health and Hospital Corporation includes our ambulance division, the Marion County Health Department, and then our health system. And our health system, Eskenazi Health, includes a hospital. We have level 1 trauma, burn center, an urban hospital campus. We also have a federally qualified health center. In fact, the largest FQHC in the state of Indiana, which is Eskenazi Health Center. And we have about a dozen sites in the community so that we can serve people in their neighborhoods and in the communities where they live and work. And we also have a mental health division and several locations as part of a community mental health center. So that's our footprint. Some of the MLP work touches on multiple different elements of our system as a whole. But I would say the biggest chunk of our MLP has to do with our relationship with our FQHC, with our health center. And I'm delighted that the CEO of our health center, Dr. Out's on today observing. She was actually our very first physician champion back in 2008. And and has continued to support and believe in the program over the last 15 years. So how do we staff our medical legal partnership? It's primarily through an agreement we have with Indiana Legal Services. They are a legal services corporation. And we have a fully integrated model where providers enter referrals to the medical legal partnership in our electronic health record. The paralegals pull down those referrals in their work queue and then process them accordingly to decide how and where to distribute them within Indiana Legal Services. In addition to the support for the FQHC, we also have services at our gender health clinic, which is a specialty medicine clinic at the hospital campus, and then staffing at the community mental health center sites. And just really in the past 3 to 6 months, we have committed to returning in person for MLP office hours. And so I think we've seen a lot of great re-strengthening of the program and the partnerships through that in-person presence. Next slide, please. Okay, so services are similar in many ways to what we heard Rainey talk about. Housing continues to be really a predominant feature of the MLP in all of its various forms and elements that make up housing as a key factor, a key legal need. We see services around gender marker and name changes, expungement, consumer rights, immigration, family stability benefits, education law, decision-making, and guardianship. And so this has been something that we see trending a little bit differently from year to year, but really housing continues to be one of the top needs year over year. Next slide, please. Okay, so speaking of housing, during COVID, we received a $300,000 grant from our Eskenazi Health Foundation to specifically launch our housing rights and eviction helpline. So this was layered on top of our existing MLP services, and it was designed to be staffed in real time by an attorney who would answer phones 3 days a week, and patients could call in and address and try to resolve housing crises, whether it was related to eviction or habitability issues. So we were really bracing for the tsunami of evictions, not knowing when the eviction moratorium was going to end and trying to be prepared and really brace for that. So the way that was set up was so that people could get real-time advice, but also if it was appropriate, we could do extended representation to see them through a proceeding, if that made sense. As part of the project, we also recorded and scripted and produced 5 videos on knowing your rights as an Indiana renter that are on our Eskenazi Health YouTube channel. And it was a way to try to extend the life and scope of the Housing Rights and Eviction Helpline project. So that is something that, you know, patients or anyone really can just as needed pull up those videos and learn a little bit about what they might expect going into a small claims court hearing that's tomorrow and they didn't have time to get full legal counsel. Maybe they would just learn enough to know, I need to show up, here's the decorum I should be making sure that I have. So that was, this particular element of the MLP was nominated for a Gage Award in 2023, and then in 2022 for a local Love Thy Neighborhood Award. So it's something that we're proud of and that we worked closely again with Indiana Legal Services to accomplish. Next slide, please. So we've heard about our legal aid partner. We have pro bono partners as well. So law firms Faegre Drinker and then Taft both provide pro bono support when families are in need of guardianship. So if an incapacitated adult needs a decision maker in the form of an actual legal guardian, they will take on those cases. Faegre Drinker attorneys also assist with end-of-life planning, sometimes as needed, but also we host an annual legal aid wills clinic. And unfortunately, we had to suspend the annual Wills Clinic for a few years during COVID, but we are excited to be bringing that back here in a couple months in June. And this model is really nice because it's on our hospital campus, but anyone in the health system can access it. Patients come in, they sit down face-to-face with an attorney. The attorney has the laptop and forms ready to go. They're typing, drafting, printing, and then executing documents and leaving with them that same day. So it's a really great service that we end up producing often 150 executed forms in a single 4-hour block of time. So I like to think of those as high impact clinics. Next slide, please. And then we have community partners as well. So the Joseph Maley Foundation has many services, but one is the Family Support Program, where they have trained pro bono attorneys to do education-related advocacy. And so we can tap into that pro bono pool by having a relationship with that foundation. I think education advocacy is specialized, and so working with a group of people that has particularly been trained on that topic is a great way to expand our MLP access without putting more strain on our legal aid partners. And then another way that we have we're looking at for growing our medical legal partnership is in the form of a legal aid kiosk. So the Indiana Bar Foundation has deployed about 150 of these across the state, mostly in like the lobby of courtrooms or small claims court offices or libraries. And so we are looking to place one actually on our hospital campus, and it's set up to be able to have templated forms that people can complete and actually print from the machine directly. So it's a lot of self-access and potential for pro se representation, because really the idea that every single patient could have full representation from an attorney is just a challenge. And so looking at finding ways to help people bridge those and access those services through other mechanisms is really important. Next slide, please. And so in thinking about what has allowed our program to really thrive and grow and be sustained over the last 15 years, I just continue to go back to our organization's values and our mission of serving the vulnerable in our community. And that's really featured more prominently than ever right now with our Beyond Barriers project and initiative. So we have made a enormous monetary commitment and staffing commitment as an organization to generational change by working in our neighborhoods and addressing and advancing health equity. It's not really researching and trying to test social determinants of health. It's actually putting into motion things that will address social determinants of health. And so the MLP is really just one piece of addressing social determinants of health. And we're so fortunate to be part of this broader effort that is looking at things like housing as medicine, food as medicine, health equity zones that are going to be these hubs of really justice in the context of health and healthcare. And so I would be remiss if I didn't acknowledge that leadership level support for what it means to really address social determinants of health at a broad level. So that is what I have for you as an update for our MLP today. And I thank you so much for the chance to present.
Thank you, Anna, for actually coming back to our NCMLP stage to present to the MLP practitioners around the country. Thank you. And I want to see if we can actually pose to you before going into the panel discussion one of the questions that came in while Rainey was presenting. And then Rainey, if you don't mind also chiming in, I think this is the question I thought would be helpful for the entire audience to hear from both of you as practitioners about. So here's a question that came in, Anna. It's, how do you share the patient and client information, including outcomes, with physicians and healthcare providers? This is a pretty standard question that comes in from MLPs whether they're, excuse me, at the startup phase, or they have fully implemented, they're advanced, and they're trying to figure out how to improve their information sharing methods. Anna, as you take a stab at this question, we'll also provide a link to our Health Center MLP toolkit, which also points folks to an additional issue brief about information sharing.
So I think the answer to that is, it's complicated, but in terms of our paralegals that pull down the referral, they do a really nice job of then in the electronic health record, at least providing an update in terms of whether they called the patient, whether the patient engaged, or whether or not there was a breakdown in communication and they couldn't make the connection. So some notation in terms of how that referral was carried forward to the legal aid provider. It does typically stop there. They're not going to go back in then and give a full debrief on, we filed this brief in this ongoing litigation for this matter. But we do have report out sessions quarterly with our Eskenazi health leaders and our legal aid providers so that we can hear typically about a dozen success stories and see some of the data points from the quarter. So those aren't then one-to-one reports on a direct referral to, back to the provider, but it gives, I think, an overview of like the progress in general on casework and where things stand with the overall project.
Thanks, Anna. And Rainey?
Yeah. So I think the real positive in terms of being deeply integrated in the clinic here, and the way that we have built our relationships with external stakeholders, we are, it just allows us to have a much closer and readily accessible communication channel for sharing certain pieces of information. Certainly some things we don't share, just as Anna described. But in terms of communicating about the clients, maybe no-shows, scheduling, the results of the work that we've been able to do on behalf of a client, that information gets shared in various ways and at various points in terms of what might be happening with the client. But there's a monthly meeting where it's either going to be shared formally, monthly or quarterly by me. But because we depend so heavily on ensuring that our clients are stay connected to us and in communication with us, there's a constant open line of communication between us and the clinic side of the team. In terms of we are not receiving referrals through our electronic records system. And there are some reasons why that decision was made. And as much as we are exploring that, we have to, based on some responses that we've gotten, or at least comments that we've gotten from the judiciary, we are carefully sort of treading how we do that, creating how we would do that. But I tell you, to just be in a space where we can, through the existing process, getting medical records, getting key pieces of information that, we might have trouble getting from a client, to have, support services in position to get that for us. Like for housing, if we need lease agreements, those are on file here. So we can get that sort of documentation from our team of clinicians and social workers and housing folks. So I think that's kind of as much as we are doing at this moment. And then the Ryan White system, in terms of intake and grant requirements, there are documentations that every patient signs that lets them know that there will be this sharing of information by virtue of the system of care that we are operating in.
Makes sense. For those in the audience, just as a reminder, for Crescent Care, it represents that single entity umbrella sort of MLP. Whereas what Anna presented on regarding Eskenazi Health, that is your partnership between your two different, or adding those pro bono partners that Anna presented on, your various organizations are coming together and partnering, but they're still separate entities. And they're both sharing from well-established MLPs, serving either specific populations or working on various issues for all of the populations, the challenges that they are, and how they're addressing those challenges with regard to information sharing or gathering consents, depending on, as Rainey shared, specific grants already require that. And so they're able to capture that upfront and be able to share information, but not necessarily utilizing the closing the loops by sharing information through electronic data exchange. In the chat, folks will see a few of those resources shared, by the way, to help you navigate this space with regard to sharing information between the different types of services. So again, the Health Center MLP Toolkit is linked in the chat. And then we also provided a more recent issue brief written by Mallory Curran. So it's a case study where Mallory examined the process by which the electronic, exchange of data and closing the loop on that exchange was examined using the MLP program in Iowa. Rainey, jump right in.
I just wanted to add that it's also very helpful in terms of respecting the professional duties and ethics from the multidisciplinary team. And so we've got behavioral health professionals with certain duties that we respect and say, well, we understand that you cannot release that. So there are opportunities to train, to cross-train in terms of how that information gets shared. Like, what do we need that's going to help us do the work that we're trying to do to support this client, and not telling professionals what they should put in their records, but like, this is what, when you're trying to figure out what you should or can release, these are the pieces that we need to do the work that we're doing. So there's that continued conversation and communication around what that should look like, and opportunities for training and education is key to it.
I'm so glad you brought that up. It allows us to emphasize to folks that, MLPs are not just engaged in direct legal services for the individuals or families that they encounter, but also in the workforce development. So the training, the cross-training that is beneficial to the health center workforce, as well as the legal services teams, to better understand what healthcare providers are encountering and need, and what those legal needs really look like in the health setting. Thank you so much, Anna and Rainey, for taking that question. And thank you to Pat from the audience for posing it. We'll go into the panel discussion. Please continue to share, for the audience, please continue to share your questions, whether it's via the chat or the Q&A. I know folks may be like me and you don't know why the Q&A option isn't hovering on the screen, so that's okay. We'll do our best here. So let's go into the panel discussion. The first question we'll pose to Jackie and Marcia of the GW research team. So Jackie and Marcia, want to pose this question to you, and then Rainey and Anna, let us know if you'd like to add on to the response. What is something that you did not ask MLPs in the environmental scan? I know, Jackie, we did receive some questions already, and you answered some of this, but what are some of the other questions that you did not ask but would like to learn more about or explore?
Thanks, Bethany. Yeah, I was going to say we already touched on a couple, the breakdown of legal issues that MLPs are addressing, and best practices. But also, I think it'd be really interesting to learn more about how MLP staff is integrated into healthcare teams, what that looks like, how often you're meeting with healthcare teams. Also, the types of data systems or technology that helps, kind of like we were just talking about, exchange data, make referrals, but also, what should be in place in order for health centers to build up their MLP programs. Also, another thing that I guess is not so much that we didn't ask it, but in the presentation, when I mentioned that we had about a dozen health centers indicate that their MLP was no longer in operation, something to explore could be what puts a MLP at risk. What are those like red flags or signals that we should look for? Especially because we saw that a majority are receive funding from external, sources like grants, and so they can be of course, very helpful, but grants for the most part end, and you don't always know if they'll be renewed. So, those kinds of things. Marcia, was there anything else?
Yeah, I think that we've tried several times to get good financial information from MLPs, not so much in this shorter version of a survey, but in prior surveys. And it's very complicated. It's hard to do in a survey form. So some MLPs receive actual dedicated funding from their health centers. And some MLPs operate without any funding whatsoever, but there is some staff time that obviously is associated with that. So really to understand the dynamics of eventually getting MLP staff or infrastructure into a budget line in a health center would be a good thing to understand a little bit more.
Agree, totally agree on all aspects of what both of you just shared. It is extremely complicated. It varies greatly around the country. And even when you look at one, it's like looking at moving parts. So yes, and would love to still learn more. Thanks, Marcia and Jackie. Rainey or Anna, do you want to add anything to that about what you would like to have been asked? Okay, we do have questions for you. Let's go to the question for Rainey. Sorry, go ahead, Rainey.
I think what I'd like to know, and this is partially because we are sort of like, in terms of where we're headed, one of the things that we're trying to do is figure out how to track the impact of the work that we're doing on the clinical side. So I can talk the numbers, I can talk I can show like the settlement funds, I can show that, but some of that non-economical sort of like dealing with the no-shows and having that legal service intervention, and how does that help or benefit the health outcome, those sorts of things. I think being more intentional around that is where we're trying to go, and I'd love to know how other clinics are doing that. If that data is already available, how are they using it?
Mm-hmm. Great question. That's helpful to folks nationwide. Yep. And it's across the board in the social determinants of health and social needs and intervention space. Agreed. Rainey, since you just had the mic, I want to move to your discussion question. Would you, and then Anna will get to yours, and we'll get to a couple of those questions that just came in via the Q&A. So Rainey, do you have any lessons learned or challenges that you feel comfortable sharing with folks that your MLP faced as a result of the COVID-19 pandemic?
So yeah, I think one of the things that we learned was that we had to be willing to pivot and move away from where we had historically always been able to direct our resources in terms of the kinds of work that we were doing. When the pandemic hit, the model changed. We went to a remote operation, and then in the midst of the pandemic, we had a hurricane that then displaced us and a lot of our clients. And so working between those two challenges, we had to redesign how we were operating, how would we do the work that we do remotely with our clients, as much as we have been preparing for that for statewide operations. But then how do we, the challenge was how do we stay connected with the partners externally that we depend heavily upon to get those clients connected to us. It's one thing to be integrated into Crescent Care's system, but 15 organizations where we don't operate like that, and staff turnover, and with staff having their own challenges with these incidences was quite challenging for us to keep to maintain our visibility, our voice, to continue to advocate for our clients. And it took us several months before we could travel to those various locations and meet with our clients. But I think those were the challenges, but I think we rose to the call and we did it. And the results of that is that we, as much as there was a shift in terms of the number of referrals that we were receiving, the clients still know we're here. The providers still know we're here. And so we're starting to see that, the benefit of staying connected through various ways. But really, I think, and then developing those pieces that would reach the broader community with shifting issues and policies and all of those things rolling out. So we weren't doing unemployment compensation defense, but we had to do that work because everybody else, every legal aid program was swamped. So we couldn't make those referrals, right? We had to step into an eviction space, and that's not work we do. But we had to step in that space and address those issues as well. So pivoting when there was a need, but then, maintaining relationships with legal aid communities so that when the things sort of began to reach some sort of, I don't know if it ever got calm, but the ability to send cases back over to them is what we were able to do.
Rainey, appreciate you pausing even and saying the word calm or, some semblance of normalcy, because I feel like that's what Anna, you were alluding to when you talked about how you all are for the MLP are also now getting back to going in person. Let's pose continuing along the same lines, Anna. Let's go to the question that's posed to you, because Rainey talked about how, for patients or clients, how to continue to engage them. The question for you, Anna, is how do you keep those stakeholders, and if you don't mind identifying some of those stakeholders, informed and engaged, which is inclusive of your, patients or clients, but additional stakeholders?
So I think that the answer to this is sort of twofold. So the stakeholders that I think of are actually our various systems that I talked about. So our mental health, our FQHC, our gender clinic. And the reason I identify those is because the way our MLP is funded is primarily through this combined or aggregated fund that these different departments collectively contribute to then staff through Indiana Legal Services. And so they all have investment from their budgets, these different areas in the program. And so then when we have our quarterly report out meetings, it's the CEOs from the different divisions then that are on and hearing about the work and the return on the investment that they are making from their budgets. And so that it's an excellent meeting that is well attended. We get great data from our legal aid partners and engaged and excited health care staff that are wanting to know more and continue showing up every quarter to get that information. And then the other part of that is we have a super user group that is different from that group, but it's more of our frontline social workers and physicians interfacing with our legal aid providers to figure out I don't really like how this reads in the referral options in the electronic health record. Let's bring in our Epic health record people to tinker with the options and the settings. And so then that's a better choice for the frontline providers to select from. And it's helpful to our legal aid providers when they're pulling in the referral that they know a little bit more about it's not just this broad family law topic, it's actually specific to child support and in this particular context of XYZ. So taking feedback from those super user groups to then improve, just constantly looking for ways to improve the program. So those are some of our, I would say, major features of how we keep everyone engaged and working towards growth and improvement.
Speaking of growth and improvement, Anna, I don't know if you want to take a quick stab at this for issues for legal needs that are emerging or arising, and your legal partners that may be funded by LSC grants and have restrictions. How are you beginning to address those emerging legal needs that don't squarely fit within, or you might not be able to serve right now because of LSC restrictions?
Yeah, I think continuing to define what the restrictions are and what LSC can and cannot allow is just something that we are always trying to improve our communication around. We don't ever want to like chill referrals because of the fear that they wouldn't be accepted by the legal service corporation. So just trying to figure out how to train the providers on truly what our legal aid partner can and cannot take within their funding restrictions is really important. And then also looking for other, opportunities. So is it a pro bono partnership that takes a particular type of case? Is it, trying to layer in non-LSC referrals? Is it the kiosk that we don't have installed yet? So I'll be eager to see if there's any thing embedded in that hits on one of the unmet needs. So I think that's constantly something we are working to try to make sure we don't have any holes or gaps in the comprehensive services that we work so hard to try to provide for our patients. But we're certainly seeing a lot more like Haitian Creole patients coming through our system, and so this is trying to respond in the moment to what kind of patient trends we're seeing is so important.
Mm-hmm. Thanks, Anna. Thanks, Rainey. I want to see if Amali can pose one question that came in from the Q&A because we're just about at time. Amali, want to read that question out that came in from Dawn, please.
Sure thing. So we got a question asking whether in those states where value-based care has been implemented, whether that has any potential for improving the scalability or the sustainability for MLPs.
And Marsha, we want to see if you in your quality.
I was just going to mention that I would, that's a fantastic question. And we looked at that several years ago, although these things are changing rapidly. And the answer was not much. It was a very tenuous kind of relationship. MLPs are small. There had been a few examples of MLPs being sort of a premier activity that promised better health and was tied to social determinants, which in turn was tied to some value-based payments, but it was not very common. So I think that would be a really nice question to pose, to do some work around, to look at those states. Mm-hmm. So fantastic question. Mm-hmm. Answers to be
posed.
Yeah.
Yes, to be posed, and we'll see what the response, what comes in. Marsha, thank you so much for taking a stab at that. Can't wait to dive into that as well. And I think you had just unmuted, and let's see, and Rainey, do you all want to chime in on that last question that came in? Okay. All right. So we're right at time. And I just want to, first of all, before we miss an opportunity to do so, thank the audience for joining us today. We know you're stepping away from your day-to-day work to learn more about what's currently being done by Health Center Medical Legal Partnerships. Secondly, I want to sincerely thank the entire panel, not just for supporting us on today's webinar, but also filling out that Health Center MLP environmental scan. We know that you've been surveyed over and over and over, especially throughout the duration of the pandemic. So starting with Marsha, Jackie, and Jen, who's I think in the audience, but not on the speaking panel, for helping the National Center for Medical Legal Partnership once again conduct an MLP environmental scan of health centers to learn more. And then also Anna from Eskenazi Health and Rainey from Crescent Care in New Orleans for providing to the Health Center MLP field more information about their models and how they have continued to successfully implement them, and also face and overcome and discover new ways to overcome those challenges that many of you are facing. For those of you who have attended, please take a moment. Again, this is HRSA funded, and we always like to know at the National Center if these trainings are helpful. What did you gain from them? So take a moment. Amali says plugged the link to our post-attendance survey in the chat. We greatly appreciate you taking just a moment to fill that out. It's just a couple of questions seriously to ask. Did we do well? We hope we did. With that, just want to let everyone know, again, this webinar has been recorded, and both the recording and the slides will be made available as soon as everything is rendered and been cleaned up in just a couple of business days on the National Center for Medical Legal Partnership website. And Reha, would you mind scrolling to the resources slide, the very last slide? So I'll just remind folks that if they Look out for it. Oh, actually, Reha, thank you. So remember, a fact sheet is forthcoming with the findings, and we'll also spotlight a third health center MLP, Cherry Health up in Michigan, that didn't present today, but we still wanted to spotlight. So look out for all 3 health center MLP models spotlighted in the findings fact sheet that's coming a little bit later this spring. And then finally, those resources that are shared in the slide deck include a link to the Health Center MLP Toolkit, as well as an earlier published MLP survey and report that the Georgetown University Health Just Alliance MLP team produced. So that's the academic MLP issue brief. Take a look at both of these to learn how to implement your medical legal partnerships and about the various settings, the health center and academic MLP settings where these come about. Thank you again, everyone, for joining us. Thank you again to the panel. We greatly appreciate all the work that you're doing to address and prevent the social drivers of health from harming the health of your patient populations. Keep doing the good work that you're doing. Thanks again, everyone. Take care.
Thank you.